To our session on the disaster health and infrastructure. This session is, these two panels are supported by Dr. Professor Dietschio from George Mason University, he's sitting there, and myself, and also by the World Medical and Health Policy Journal, which says WMHPJ. Basically, you all hear that nobody is safe from disasters. This morning there was another earthquake in Japan, 7.2 on the Richter scale, which was in the same area where it happened last year, and people evacuated, but fortunately there was minimal damage, no deaths, a couple of injuries, and only a 3-foot wave which came up, so there was no tsunami. But natural disasters, natural and human-made disasters are part of our life now. And as you witnessed, just the recent one was the Popa in Philippines, and the one closer to home is Sandy. And those disasters really do occur on a regular basis all over the world. There was, I thought, another earthquake and another hurricane someplace just yesterday. The good news, the bad news is that there are a lot of hurricanes and a lot of earthquakes, and mostly the weather inclements are the ones which cause most of the damage. So the good news are we are better prepared, we can evacuate people, we have fewer deaths. The bad news is that it starts to cost us a lot of money because the infrastructure is destroyed, and the health effect, long-term health effect, are going to be starting to be felt. One of the things that probably we have not seen, and we'll discuss probably later on by the panelists, is that once you have such vast devastation, you have toxic exposures and long-term effect from cancer and other spills that are happening will be prominent in as a long-term care for the people who and the victim who has suffered disaster. Also displacement and loss of property, loss of shelter in the worst time is becoming a fact of life. So today, the panel one will explore the disasters, health, and disparities, and the panel two that Professor Dietschio will be having his panel talk to will be infrastructure and disasters. We switched it a little bit, talked about health effects, and we have two wonderful speakers here, good experts in their field. Dr. James C. Polk, who is sitting, first one sitting there in darker suit, and he's the Principal Deputy Assistant Secretary and Deputy Chief Medical Officer, Department of Homeland Security. He is, I always call he's one of our own. Before that, he was Chief Space Medicine at Johnson Space Center, participating in the psychological and physiological support of the Chilean miners disaster which happened 2 years ago. He is a doctor of osteopathy, emergency physician, still in the military, in the reserves, and flies periodically when he has time and money. But he was trained, lived in Texas, trained in Ohio, and was the director of medical disaster management in Ohio, and also practicing emergency room physicians. That's what he does for a living. So I know you want to hear about the stories, not about the speakers. They can add to whatever they want to later on. And Dr. Dan Hanfling is also an old friend, and he is at INOVA Fairfax. I'm not supposed to mention that he's part of the team too, right? Which is one of the best teams for search and rescue and disaster. He was participated in many disasters, including the terrorist attack in 2011. He was part of that rescue. I'm sorry, 2001, 9/11. He is chair of the Special Advisor Emergency Preparedness and Response, INOVA Health System, clinical professor of emergency medicine, George Washington University, and distinguished fellow at George Mason University. He has many more titles, published a lot. But he was, just to let you know that there are ways to recognize a person's contribution. He is a co-chair of the IOM, National Academy of Sciences, Institute of Medicine, National Academies, excuse me, Institute of Medicine panel on study panel on the disaster, medical disaster management, and they are now writing several reports in that area. So he is an expert in that area. Well, the two objectives, the panelists, one will review lessons learned and policy addressing medical disaster preparedness, resilience, and reducing impacts on vulnerable population. That will be from the policy standpoint, Dr. Polk. And Dr. Hanfling has always been, both of them had always boots on the ground, but Dr. Hanfling also is actively engaged at this point. He will discuss the health consequences of disasters and planning for international humanitarian response. Just to let you know quickly that between 2005, just contrast 2005, if you recall, was the hurricane for Rita and Katrina. The death toll in 2005 just from Katrina was 1,833 people with $81 billion of damages. That got in trouble with Cuomo when he said that New York was the worst one recently. Katrina was the worst one. Together with Rita, they were kind of much more severe. And our current one, which was the Sandy, where people are still having trouble in Long Island. Long Island. Is had 121 deaths and 70 billion damage. But the people who were affected were close to 10 million people. And the Bhopal, which was hit there, but the village of Batan in Mindanao was killed a little bit over 500 people because of exposure. Most of them were evacuated, but the damages, we are not sure how much it is, probably not as much as the United States. So what were the infrastructure and assets which were affected in all of those? Well, power generation and distribution is gone, which affect exposure of people. Information and telecommunication, rescue and so forth, the medical folks cannot work with it without that. Water and food supply, obviously, agricultural distribution. Those are the ones which go and have direct consequences on the health. The second, the yellow ones are medical and public health services. In New York, were what, 3 hospitals closed or 4 hospitals closed? 4? 6? 4 yeah, 4 were evacuated. Katrina also witnessed New Orleans hospital evacuation. Transportation is affected, security service, banking, financial services. You know, people have to have a lot of change to buy things because the information technology doesn't work. You cannot buy things using your credit card. Postal services are affected. Critical manufacturing is affected. But the military is not, and that's why the military provides special assistance, always within 72 hours. So health impact of disasters in a nutshell: near term are injuries, infection, environmental and toxic exposures, and death. And the chronic one that we all witness after years will be physical disability, amputees and everything else, psychological problem, post-traumatic stress disorder, cardiovascular disorders, addiction to alcohol, and whatever people can get addicted. And now we don't know, we know after 9/11, the Twin Towers, which crumbled, created a lot of pulmonary hazards and pulmonary problems from the dust over wide areas. So exposures becoming a more serious problem as more people survive. And with that, I believe that's the end of my slides, and I would like to turn over to Dr. J.D. Polk. And thank you for being here. And you want to have the questions at the end?
Your choice.
Whatever. If you want to ask in the, during the presentation, by all means. So Dr. Polk is the next to follow. Go ahead. I don't open it.
Got it? Perfect.
Thank you.
Well, good morning. Most folks probably realize that FEMA is part of Homeland Security. Homeland Security obviously came to be into being shortly after the attacks on the Twin Towers in 9/11 in 2001. And so we're actually, in a couple of months, actually have our 10th anniversary. As a government agency, we're still extremely new. And we are a conglomeration of 22 different components that were essentially thrown into a kettle together to become this agency. Secret Service, Customs Border Protection, FEMA, the Coast Guard, et cetera. What we've learned over the last decade, even though we were born out of an anti-terrorism mission, is an all-hazards response mission. Because of the hurricanes, the tornadoes, blizzards, you name it, that we continually have to respond to and be diligent for. And so what I'm going to go over is, at least from a policy standpoint, how we approach it and what we think about in terms of resilience, for disaster resilience, and why very often we have to keep repeating history in terms of whether or not communities are prepared or not. Next slide. When we talk about resilience, I think it's Nassim Taleb has a book that's called The Black Swan, and preparing for events that are rare or never events. And these are very difficult, quite frankly, from a financial or policy perspective, especially when you're in austere times such as we are now with fiscal climates and folks arguing over fiscal cliffs, et cetera. It's very difficult, especially on a local level, in a local community, to spend money on something that may happen or might happen in the next decade or 2 decades, et cetera. But however, what we've seen is that if folks don't spend at least some money on the infrastructure and the ability to be resilient, that there are what we call secondary cascade effects. And there's an old saying that if you've seen one disaster, you've seen one disaster. But there are some things that we've come to recognize that are predictable. And just to give an example, which Dan will probably touch on as well, but with the New York hurricane and New Jersey with Sandy, there are some things that we know, especially in healthcare and patient populations, that are going to have certain needs. For example, folks that are on dialysis, if the dialysis centers don't have power and they don't have water, those folks are going to need to be cared for sometime within about a 72-hour period. Folks that are diabetic, folks that have COPD and asthma, if they're not able to plug in their aerosol machines because they don't have power. So you can actually plan for those things. You can plan for where you're going to set up the dialysis center. You can plan for whether or not you're going to have a gymnasium with power strips that line the center of it with folks to plug in their aerosols, et cetera. And those things can prevent a cascade of people clogging the arteries of the emergency department with just some planning. And so those are some of the things that we try to teach communities as they become resilient. We try to teach them mostly to avoid the second order effects. Most folks know with a disaster where you're never going to avoid all the damage, whether it's a hurricane, whether it's a tornado, whether it's an act of terrorism. But what we see is a large portion of the cost and a large portion of the problems that cascade are second order effects. People did want to spend money on upgrading the power grid. And so now we're seeing second order effects from that decision, et cetera. Next. And so, when we talk about resilience, Craig Fugate, who's the administrator of FEMA, when he was the disaster administrator in Florida, used to have what he called the Waffle House Index, which everybody kind of laughed about. But actually, when you think about it, you know, he still uses that term, and it makes sense. From his standpoint, he wanted to know when the Waffle Houses were operating after a hurricane in Florida. And that was kind of an index. It was a measure that if that business opened up, because the Waffle Houses were known that, you know, they didn't want to lose business. They're a 24-hour restaurant throughout the South, and if they had power and people had gas to drive there, then you knew the infrastructure was coming back. And that was kind of a tipping point, if you will, as to what side of the equation you were on the inflection point after a disaster. And so, you know, whenever he would talk about the Waffle House Index, people would laugh, but they only laughed once because Craig was dead serious about it. And we use a similar metric on that. You know, when are the schools open? When are the businesses open again? The hospitals are a big infrastructure component for us. If the hospitals have to close, then where do those patients go? And can the surrounding communities absorb all of those patients? And with our NDMS system, where is the tipping point there to where the hospitals can no longer accept more and more and more patients from those that have closed? And you know, what are their plans? Are there agreements between hospitals and between communities to ship or accept those patients? For us at DHS and at FEMA, we're a logistics agency. You know, all disasters are local. They are local by definition. The local community is working those. We try to enable and support by whether it's shipping temporary housing, putting workers in, writing contracts for EMS, writing contracts to allow 300 power companies to send all their workers into New York and New Jersey. But we don't actually, you know, manage the disaster for them. We help them when we enable them, but it's still the local and state community that does that. And so very often what we look for are tipping points ourselves, or where can the community no longer help, or where is the community overburdened, or where are they overtasked, and where do we need to bring federal resources. For example, in New York and New Jersey, we looked at when is the appropriate time, or should we bring the hospital ship, the Comfort or the Hope, up into the harbor. We didn't deploy that. It's a multi-million-dollar asset, and you know, it's not something you can just turn on a dime. It takes us some time to put that ship in the harbor. But you know, we look for the tipping point for how many hospitals. You know, is it 6? Is it 8? Is it 10? Where does that occur before we need to start deploying those assets? Next slide. For us, the non-natural events are the other thing that we look at. We take, and it's very difficult, especially you know when you are starting a bioterrorism program or you have collectors. If you're starting that right after the anthrax letters in 2001, you've got a lot of support and a lot of finances and a lot of energy. But after a decade, as with all disasters, tincture of time, you know, decreases to the support. Folks start to wonder: is that still a threat? Do we still need to spend money on it, et cetera? And that's typically what we see happens: is that support erodes, whether it's on a local level, whether it's on a state level or a federal level, over time until another disaster occurs, and then it peaks again, and the spending peaks again. Part of our job at Homeland Security is to try to obviously keep diligent on those Black Swan events and to make sure that we are not putting the nation at risk, and to argue to Congress as to why those things are still important, to try to prevent those inflection points. Next. From a healthcare cost standpoint, if you look at just the disasters that have occurred, and the natural disasters that have occurred in a short span of time, and this was one journal article, it was from the Health Affairs, November 2011. The healthcare costs just from the heat waves, hurricanes, wildfires, et cetera, were close to $14.1 billion. That's a lot of money from healthcare costs just from natural disasters. Next. And the thing that we look at in what we call our QHSR, which is our quarterly Homeland Security review, which is our strategy for what are we going to have to spend money on and pay attention to over the next decade, is that whether you believe it is a natural phenomenon or a man-made phenomenon, for global warming, we are seeing trends. We're seeing trends of increasing hurricanes. We're seeing increasing powerful hurricanes. We're seeing less spending on infrastructure because of the fiscal climate. We're seeing increasing disease transmission. If you look at the West Nile virus that rampaged through the South this year, we're seeing increase of migration from folks from the South, and so we have more issues with our Customs and Border Protection folks because of drought, because of disasters that are occurring in the form of agricultural disasters in different countries, and we're seeing dwindling food supplies and thus a lot of increase in migration to the U.S. And a lot more storms and flooding, as I mentioned. So we anticipate that we're going to have an increasing role in those, and that FEMA's job and spending is going to be higher because of that. And so we as an agency also have to be resilient and diligent to make sure that we can enable the local communities and the state communities as well. So that, in a nutshell, is how we approach it, and how, from a policy perspective, very often it is an ongoing risk for us to continue to argue for the assets, whether they're financial or personnel, to make sure that we have the resources in place as these disasters occur. And I'll turn it over to Dan, and certainly any questions folks have, I'll take at the end.
Roll into mine. So thanks, JD. So it's a pleasure to be here. Thanks, Arnold, for the invitation, and Dr. Polk, excellent presentation. So my comments are going to be focused on the international disaster response arena, and I will start with a disclaimer that I didn't hear from my good colleague, that the comments that I'm going to make are mine. They don't represent INOVA Health System, FEMA, USAID, or the Institute of Medicine, all of which I have direct affiliations with regards to these issues.
I'll say ditto. How's that?
There you go.
Am I covered?
I'm keeping you honest. So, and what I'm going to talk about emanates from work that we recently completed at the Institute of Medicine on the issue of describing what we call crisis standards of care, a framework for catastrophic disaster response. Next slide. And so the point is going to be, can we look at putting in place a framework that is now slowly but surely being adapted and adopted in the United States and finding its way into current grant guidance, particularly with regards to CDC and ASPR grant guidance around hospital and public health preparedness, and see if this framework is applicable in the international arena. Now, the starting point for this discussion is that there is no single organization that's responsible for international humanitarian assistance or international disaster response. These are ad hoc, somewhat disorganized efforts that bring a lot of actors and a lot of players together in response to a given event. Take Haiti or the any of the disasters that you can think of in the international arena that have occurred in the last decade. These are seemingly governed by their own sort of energy, without any single international organization that's responsible for organizing. Next slide. So the starting point is to understand really what constitutes catastrophic disaster. And so I go back to the social scientist Quarantelli from University of Delaware, who I think describes in the clearest terms really what is meant by catastrophic disaster. There are four specific attributes. The first is that there's loss of community infrastructure. The second is that that local officials, because of that loss, are unable to perform their functions. And this occurs for an extended period of time. As a result of that, the routine community functions, those issues that you heard Dr. Polk describe, schools and businesses and healthcare operations and so on, are not functioning, and they're not able to be performed. And the fourth attribute is that because of the pervasive and extensive nature of the events, collar communities, neighboring communities, regional efforts are also not likely or are unable to come in to provide assistance because of the wide geographic expanse of events. So in the Quarantelli definition, these are really the attributes of catastrophic disaster. Next slide. So Taking that definition then, my spin on really what the attributes of conventional disaster are basically sort of the negative image of those points. The first is that these events do not stress either the capacity or the capability of communities to be able to deliver care. So in other words, 9/11 is a disaster, it's not a catastrophe. H1N1, barely even rising to the level of disaster. The event is neither sustained or is it unprecedented. And with regards to the delivery of medical care in disaster, for the most part, is delivered under usual circumstances. Next slide. Now this is important because in the work that we've done over the last 3 years in the Institute of Medicine, focusing on what we describe as crisis standards of care, we focused on an area of work that has really been in place, I'd say, certainly since the 9/11 and anthrax attacks, and that is focusing on what we call surge capacity. And surge capacity in the healthcare arena is meant to describe how to deliver increased services of healthcare when the demand goes up in response to any given event. And for the longest time, surge capacity, I think, has really been thought of as an all or none phenomenon. And in fact, what we try to lay out is the fact that really surge capacity occurs over a continuum. And the continuum that we describe ranges from conventional surge capacity to contingency surge capacity to crisis surge capacity. And important to healthcare providers is the attendant standards of care that accompany that transition across that continuum. So that in conventional surge capacity, you really are operating under conventional standards of care. In crisis surge capacity, you're really operating under crisis standards of care. And that really sort of forms the fundamental principle of the work that we've done. Next slide. So in the context of international disaster response then, where also these events are not all or none phenomenon, they're not all crises necessarily, and yet we have seen, now Haiti was a crisis for sure. That met every attribute of the initial definition. But there are many other events like the tsunami in Japan, where for the most part infrastructure was intact. The healthcare system outside of the impacted zone was intact. And so you begin to see that really maybe there's some applicability to this continuum approach in looking at international disaster response. Now, the issues, because of the absence of a single organizing and unifying element in the international community, means that there are issues related to standards of care, competencies of responders, accountability of those responding agencies and actors, the issue of how to classify foreign medical teams who come in to respond to disaster events, and then the professionalization of those who respond. So while, for the most part, in my experience over the last 15 years in the international arena, there are many, many actors who present, many of the NGOs who come, all meaning to do well. But are they really at the level that is required, particularly in the most austere of circumstances? Next slide. So again, sticking with this notion of this continuum, then maybe there is room for consideration of applying such a continuum in looking at these international events. And again, if you look on the left-hand side, sort of that conventional contingency crisis, you see what the impact is across the boards with regards to effect on standard of care, the use of resources, the practice of participants who are responding, and ultimately where the focus of patient care is. And the important point to highlight from this slide is that in crisis events, you really are transitioning from patient-focused outcomes to population-based outcomes. And this is really a fundamental tenet of public health. But again, something that we don't always consider in our response. Next slide. So how is this defined and how might this be applied in the international arena? Conventional surge response really describes the space that's required for usual patient care delivery, the resources that are required, the staff who are going to be delivering that care. And in a large-scale event that really stays within the conventional realm as defined in that last slide, the need for international humanitarian assistance disaster response is plus or minus. And it may not actually require the full deployment of either state-based or NGO-based response elements. Next slide. As you get into the contingency surge response, where essentially you are providing functionally equivalent care, but the delivery of care begins to change along that spectrum because of the circumstances and the beginning of resource constraint issues. This is where there is likely the need for some degree of response where you are having, again, state and NGO-based actors responding in the international arena. But it is certainly not, next slide, Arnold, it is certainly not at the point of a crisis surge response where now you are really adapting care to the circumstances because of pervasive and comprehensive infrastructure loss, et cetera, where the arrival of international medical assistance is required both to to reestablish existing capabilities on the ground, as well as to ensure that the pre-event healthcare delivery needs are being met. So this is where you really would see the need for international response. Next slide. So the key considerations in looking at these issues are, what's the status of healthcare delivery in the affected country prior to the event? Because as we learned in Haiti, we brought a higher level of care into Haiti after the earthquake in 2010 than existed prior to the events. And there ought to be some commensurate approach to the delivery of health care, because otherwise you really are establishing unsustainable expectations. What are the expectations regarding the delivery of emergent and acute care and the resumption of chronic care? And what is the commitment to ensuring long-term recovery? So from an ethics perspective, it's critically important to look at these international response elements as ensuring that you are not just coming in on the front end, like the cavalry, but that you are ensuring your commitment on the long term to recovery. And that, I think, needs to be understood, and particularly when we talk about NGO actors who come in on the front end, do whatever they can do, and pull out. Well, they pull out, and what happens to all of the systems or patients or elements that they've provided? We need to do better than we've done up until this point in time. Next slide. So just rounding this out, in thinking about potentially bringing this up as a framework for consideration, you have to consider the context of the affected nation and the specifics with regards to whether you're talking about a failed state like Haiti, a developing nation like India, where I'll be this week, or a developed nation like Japan, which was, again, very organized in its response. You have to look at the type of disaster event, because there are different types of events that will really govern the type of response that would be required. Let's put it like that. And then finally, the setting and the condition in which this happens. Is it mostly an urban environment, a rural environment, and so on? Next slide. So the recommendation would be to look at considering bringing this to WHO and considering adoption of a crisis response framework at the acute onset of these events, so that there is a roadmap, if you will, for understanding what the expectations are and where the expectations would be with regards to delivery of care over a conventional contingency or crisis response, and what governs that response. The notion is to steward the use of resources to attain achievable, desirable outcomes. This would be consensus-driven, and it would be delivered within the context of what is already the existing mechanism, which is the use of the health clusters to organize and coordinate operational response on the ground in any given event. So this recognizes the sovereignty of the host nation as sort of driving these issues. It develops consistent use of foreign medical teams based on a classification approach. It sets those goals for long-term recovery, and then includes pieces, for example, like palliative care, which have not been entered into the discussion to this point in time. I think that's the last slide. Okay, so here's what the framework looks like. Meets the standards, and really highlights, sort of goes around the central piece, which is that there is still the absence of or need for a global authority with regards to international disaster response. And next slide. There you go. So, so again, my thoughts based on work that we've done here and that we're beginning to implement with regards to policy and operations in the United States. And turn it back to Arnauld.
Thank you very much. Appreciate it. Questions?
Yes, sir.
So I've got a question. I think it's particularly for the last speaker here, but overall, these were terrific talks, and I love the framework idea. But could you say a little about how you bring the public along with this? So this makes terrific sense, but I just picturing explaining it to people after the fact. And particularly in the U.S., we have this attitude that somehow, gee, if you're in intensive care or something, when Katrina strikes, you've got rights that transcend any dollar amounts that might be involved and so on.
Yeah, so if it's okay, I'll start with that, because what I would refer you and all of the participants this morning to look at, if you Google IOM Crisis Standards of Care or IOM CSC, you'll come up with our 2009 letter report and then our March 2012 7-volume report, which really gets to the heart of the matter that you just described. And that is that none of this work means anything unless we have two critical pieces in place. One is provider engagement. In other words, the collection of those of us who practice and have to affect these changes, getting on board and recognizing that it's going to be a transition from the usual manner in which we deliver medical care to these contingency or crisis modes. And the second is community engagement. And in the 2012 report, one of those 7 chapters is an entire chapter focused specifically on the issue of community engagement. And we were funded actually to go and put together a toolkit for having these conversations with the community. We actually we piloted it in Boston and in Lawrence, Massachusetts. 2 very different communities, as you can imagine. Everyone had 2 PhDs, I think, in the Boston crowd. And in Lawrence, a very working class, mostly Hispanic, very economically depressed. And it was remarkable. In each of those 2 distinct communities, the public, number one, really wanted to be there, wanted to have a stake in an outcome with regards to delivery of care, particularly where it relates to allocation of scarce resources, and were fully capable of engaging in the discussions that were required to decide what essentially become community-based values with regards to the allocation of those resources. So we are in the process now of sharing those tools, and public health departments across the United States have access to those tools, and we hope that we'll see more of that.
I guess I would caveat that with one thing. To give an idea on with Hurricane Ike, the primary order of effect from the hurricane itself lasted 6 to 8 hours. The second order effects are the failures from power failure and getting the infrastructure in place lasted 6 weeks. The advertisements from attorneys lasted 3 years. And so I caveat that only in that if we put those standards in place, they need to be codified somewhere, because otherwise, you're right, there is an expectation and there's a hindsight of people forget what the disaster was like, what the infrastructure was like, whether the power was failed, whether the hospital had no power and they were bagging people on the roof, and especially when you're 2-3 years out in the lawsuit, those things fade. And so making sure that we codify those crisis standards of care, I think, will be important, at least legally, for folks, and for states to adopt that as part of their legal structure, that during a crisis that we will credential people from out of state or from out of the country based on these standards, and the standards of care for a crisis will be X. Because otherwise, I think we can be well-intentioned, but unless the legal system catches up with it, it may not be workable.
I agree.
One of the major problems that we have encountered in disasters was that there is a significant amount of post-traumatic stress disorder languishing in the aftermath of the disaster for a long time. And in order to do the intervention, we need A, to educate the people, the community, and B, we need to make sure that we have adequate supply of counselors, I'm not saying psychiatrists, counselors, who can talk to the people and explain those. At this time, you know, if I were to communicate to you something, is that there is not an adequate amount of counselors. Basically, those are primarily furnished by the American Red Cross, right? And then the community has to take over and set up counseling centers and things like that. So how do you communicate with the community becomes how do you use the assets of the community? And how do you communicate to the community becomes an important issue, specifically that you have different groups within the community, such as churches, schools, and other areas that you can use very effectively to communicate, provide shelter, inform, and any good health department will be engaging into the outreach of the community. I always remember our health department director of Fairfax City, she always complained that we have 122 languages spoken in Fairfax. Well, how do we reach all that community? One way she did it, she started to engage, you know, our students who were native of the countries to go out to knock on the door and talk to the people, establish their rapport. And, you know, there are those innovative ideas which are there, how to communicate. And I think we have, at George Mason, we have Dr. Krebs, who is engaged in this communication policy and research, how to do it better. Yes.
Yeah, you know, so on the issue of psychological issues, and certainly we see these as recurrent themes with regards to you know, large-scale events. The American Red Cross during Hurricane Sandy deployed a project called SciStart, Psychological Start, Simple Triage and Rapid Treatment, which essentially is a self-filled out checklist that was put together by one of my colleagues, actually a colleague from our Institute of Medicine panel, and we described this in our report, in our March 2012 report. And it's people who can basically go through a checklist and check these off and then leave them at Red Cross centers. And there were over 20,000 of these distributed. There's data that is being amassed now that I think is going to find its way to publication that shows that it's one of a number of psychological first aid tools that can be rapidly deployed to highlight where some of those scarce resources, because as Dr. Nicogossian pointed out, psychological services are as in short supply as any of the other elements within the healthcare system. And so there are some promising tools that may be able to find their way in the midst of an event to help focus where resources are potentially required.
I have a question regarding, you know, involvement of communities, and even on an international level. I know sometimes transporting U.S. whole community first, FEMA is doing gigs there. Can that be done at an international level? I've seen it being done previously, and that's something that my organization is pushing to Haiti and other countries. If the community start with one, who's a major center of families, women. If the women involved in some of the emergency management training that's going on, psychological first aid, difficult, because even with faith-based organizations, most of your ministers, crisis management, they do that all the time.
Right.
And I've even taken psychological first aid test, and I'm like, wow, I didn't pass it. It was just so comprehensive. And we tend to look at trauma, my organization, as compounding itself. So if you have these countries, they never get over a natural disaster. Trauma is just compounding itself. So if you're looking at the community, that's the key to getting involved, even in the psychological first aid.
Yeah, I mean, I would just say that, as I put in the slide, I mean, the sovereignty and decision making and wishes of the host nation have to be the first starting point for these discussions. And I think you know, the recognition of the importance of including the community in the response, particularly in the recovery, if not on the acute side, is critically important. And I'll just give you a very simple example from our experience in Haiti, where, you know, we operated for about 2 weeks. In the immediate aftermath, we were the first team in after the collapse, except the Icelandic team that got us beat by a few hours. I don't know how that happened. And at the university Port-au-Prince site, which is where I worked for the first 7 days, where we made 4 live rescues, you know, in a very, very austere, very difficult, very dangerous environment. We made sure that we were working with the Cape Haitian Fire Service, who we had actually worked with because of a school collapse in Peytonville the year previous. They had a lot of our equipment. We had some recognition of each other. We made sure that they were the ones who were bringing those rescues off of the pile and to the families, and working with us side by side in terms of doing the things that they could do, because of the fact that, if for no other reason, it's important to demonstrate to the local community that their own responders are participating and have a stake in and a capability of playing this out. So I would say that, you know, from a USAID perspective, we understand the importance of community involvement, and I think that there will continue to be challenges and work of organizations, yours and others, that have to continue to push to get the community involved is very important.
From our concern, I want to share something very quickly with you, what we encountered after the Armenian earthquake in 1988. NASA was asked to help, and the space agency, and we put a telemedicine day to Armenia, but we came after everybody left. We came in, the earthquake was in December, same time, around December 8, we came in March. And we had limited resources. The thing which was very, very surprising to us was not only the psychological problems that people had, but the unforeseen medical conditions like increased number of heart attacks and addictions to alcohol. Well, everybody was drinking in former Soviet Union and Russia, but there was more and more addiction. And we thought it was just peculiar to that region, but then we start to find out now that most of the countries do report the long-term effect, which is heart disorders, hypertension, obesity, and maybe cancer now, looking at 9/11 and pulmonary lung problems that experienced in New Jersey and New York. And that will be, the long-term consideration is usually fall off the cliff, shall I say, that's the good word today, of the board, and nobody has the money or resources to provide the long-term support to those populations, hence the disparities. And the people who suffer the most are probably the communities which do not fare well because they are at the cusp of disaster already, stressed out. So we are very concerned about the long-term impacts. Can you? Yes, sir.
This is for Dr. Polk. You mentioned about the crisis standards here. Do you think there's any political will to actually come up with standards that would be a legal safe harbor? I mean, something as simple like the business continuity standard. You can't come, you know, there's these food funds over this type of thing. Everybody's in disagreement. You have 3 sets of standards and all this.
I personally think it would have to happen on a state-to-state basis. There's political will potentially in some states, especially after if you introduce it shortly after a disaster when the memory is still fresh. But if you look at the political will in Louisiana versus the political will of New York, they are vastly different in culture, vastly different in risk tolerance, vastly different in what they are willing to spend tax money on. And so it's hard to put a Six Sigma approach that all the states would be unilaterally accepting of such things. And I think there are some states and some localities that do disaster management extremely well. They practice it. There are exercises. There are things that you see all the time, and there are others that dismiss it offhand. And so it's very difficult to take that template and apply it to each one. And
Yeah.
Dan.
Yeah, I mean, I would just say you hit the nail on the head. It's definitely a state-by-state, process. And the Commonwealth of Virginia, as an example, state legislature in 2008 passed language that specifically and explicitly described that healthcare providers will not be held liable for decisions taken in a disaster in which allocation of scarce resources becomes the prevailing condition. So Virginia, Louisiana, a number of other states have begun to look at this. And one of the challenges is going to be not just encouraging states to look at it, but then to ensure that there's state-to-state consistency. Because, for example, Virginia, if you're practicing one way in Virginia, but you're not doing it the same way in the district in Maryland, people will vote with their feet. So we have to ensure consistency across regions. Yeah. Right. Yeah, it's a good question, and I don't know, but I'd be happy to put you in touch with my colleague who was working with American Red Cross, and get you try to understand that information. I know that the language issue has been a consideration even with our own work. It's in English. For example, in Lawrence, Massachusetts, which, as I said, is a very Hispanic population, if citizens came who were not fluent in English, we weren't able to include them, only because at this point in time we haven't translated and haven't gotten that product ready for a Spanish-speaking only population, or it could be Vietnamese right across the river in Fairfax County, what have you. So I think that there are still lots of needs and opportunities to reach populations who can be proportionally affected by disasters, and who may benefit most of all from some of these interventions.
We have to break, unfortunately. Do you guys have time after the session to talk to people?
I have a couple minutes. Yeah.
Well, thank you very much. Thank you for coming. I appreciate it.
Yeah.